Welcome to our first webinar for our 2022 season. And we are very, very happy to be doing this in partnership with the Canadian Association of Health Services and Policy Research. So I'm going to pass to Maggie.
Thank you so much. So as Ivy said, welcome to everybody to the Canadian Health Workforce January webinar today. I'm really excited to be here, both because Casper is partnering on this event and just because it's a subject that is of such great importance. I think lots of people are thinking about the health workforce currently because of pandemic, but these are certainly issues that have been plaguing us for a long time and that we've been seeking solutions for. So I'm really excited to have part of the conversation today. I'm delighted to be your moderator. As Ivy said, my name is Maggie. I'm the Executive Director at the Canadian Association for Health Services and Policy Research. I want to begin by acknowledging that we are on Indigenous lands, and we recognize that an acknowledgement of the land is only a beginning, but it's important so that we can collectively reflect on our role in repairing our nation's relationship with the original inhabitants, Turtle Island, now known as Canada. I live, work, and play within the Haldimand Tract, which is the ancestral, traditional, and unceded territory of the Six Nations of the Grand River. Today, we pay our respects and want to express our gratitude to the First Nations and Métis people who are the traditional guardians of Turtle Island. So I want to just welcome everyone today. We have an outstanding panel gathered with us today. These are some of the best people working on and thinking about health human resources in Canada. And they're with us today to share their insights about a really important issue and to talk about solutions that will pave a better path forward for the health system, for the healthcare workforce, and for all Canadians. So with me today, we have Deborah Cohen, who's the Director of Pharmaceuticals and Health Workforce Information Services at the Canadian Institute for Health Information. We have Dr. Catherine Smart, who's a pediatrician and who's the President of the Canadian Medical Association. We have with us Linda Silas, the President of the Canadian Federation of Nurses Unions, and we have Eric Sutherland, the Executive Director of the Pan-Canadian Health Data Strategy, the Public Health Agency of Canada. So as we move through what promises to be an exciting hour that is doubtless going to just whiz by, I'm going to ask you to use the chat function to ask any questions that you might have. And make sure you ask them as we're going along and as you think about them. We'll have some time for that at the end of the hour. And add in any comments that you may have. If you do happen to be tweeting about the webinar, you can use the hashtag #path4HHR. It was, I think, on Ivy's slide. So with that, let's get started. And I'd like to hand it over to Dr. Ivy Lynn Burgo for a brief presentation that will really help us to set the stage for our conversation today. Ivy?
Thank you so much, Maggie. And I'm really pleased to be able to present this potential path for improved health workforce planning, policy, and management in Canada. And, you know, if a picture is worth 1,000 words, this is the one. And so this is one of the main reasons why we need this path, but also one of the things that we stressed in the paper that was released just before Christmas with the School of Public Policy is that there's a critical coordinating and convening role for the federal government to play in addressing essentially 8% of its GDP. And as Maggie mentioned, we're using the hashtag #path4HHR if you are tweeting today. So I'm going to spend very little time on this because I think if we turn on the news, you know what the burning platform is. Health workers experience endemic levels of burnout and work overload. This is leading to attrition and increased vacancies like we have not seen before. And this was actually prior to the pandemic. These are longstanding concerns. The pandemic has exacerbated these trends, causing critical and systemic risks to our system in the short and long term. And this has important implications for patient safety and patient access as we see wait times that were already problematic before the pandemic go up significantly, and the stories that we hear. These risks we trace back in an upstream kind of way as a direct result of poor staffing, poor planning, which in turn are a result of poor workforce data. This is remarkable that we have such poor data in Canada. One of the cases that's made in this paper is that the federal government has an important coordinating role to play. Pictured here are the variety of different health workforce stakeholders that exist within a complex adaptive health workforce system, and that without a federal coordinating role, this is a very fragmented system. We have folks here represented, unions and professional associations that represent the interests of all health workers, and they collect data on their members, and regulatory authorities represent the interests of the public through standards. They collect data. CIHI and StatsCan tries to consolidate some of those data. Health workforce scientists try to use those data and build science in this area to help inform planning. Educators are trying to make evidence-informed decisions about enrollment and faculty and workloads, etc. And employers are trying to identify data needs to support staffing decision-making. So each of these stakeholders has some data, it's disparate, and overarching, we need to have some type of coordinating role. So this isn't just me saying this in a policy brief. This is something that over 60 national health professional and leadership organizations have signed on to in our call to action. And nearly 300 individual researchers, health professionals, hospital CEOs, and others. And if you haven't signed on to our petition, please do so below. What is it that we call for in this call for action? To establish a health workforce agency or observatory. And it's important to kind of highlight what would that type of organization do. So this is building on a review undertaken in 2011 from the World Health Organization on the integrated functions of a health workforce agency or observatory. First of all is to collect and synthesize and share standardized data. We need to do that in an integrated way in order to develop early warning systems, right? So that we could project, what is going to be happening in the near future. So those data need to go into plans to develop decision-making tools for those who have to make decisions across the different stakeholders. Health workforce agencies also curate evidence and share strategies. And this is really important in the pandemic in terms of what works in one location, what doesn't work, what should we no longer do, what should we do more of. We haven't been doing that. And other functions are to fund and conduct applied research and policy analysis, which we are woefully adequate on in Canada. To develop partnerships and mobilize stakeholders, and also to build capacity and facilitate networking so that we are all working together, moving in a common direction for important goals, such as, the quadruple aim. This call that we have, it's not new. There have been calls for this before. The House of Commons Standing Committee on Health called for a health workforce observatory in 2010. The Naylor report on health innovations highlighted a need for the need to create effective collaborative linkages amongst health workforce stakeholders in 2015. And examples exist in Canada in other sectors. Pictured here is BuildForce Canada, which undertakes labor market information, training, recruitment and retention and management resources, and has been doing this for 20 years in Canada as a partnership. And this is also looking at sectors that are provincially regulated as well. Important point is that the construction sector constitutes 7% of our GDP, and health workforce, as I mentioned at the outset, 8% of our GDP. So this is really, really egregious that we don't have anything like this. Canada is also exceptional internationally. And I'm just drawing on two examples here of countries that we often compare ourselves to, and often because they are federated systems and there is a balance of power between federal and state or territorial governments. APRA in Australia moved to nationally coordinated registration in 2010, the same year that our House of Commons Standing Committee recommended that we do this. So this enabled the creation of a standardized national health workforce data set of 16 professions. So this was in turn created into a heads-up tool, which is a digital decision-making platform that draws upon this national asset that they describe it as a national asset for health workforce planning, so that they have had a ready infrastructure for a more effective pandemic response for the workforce. That's one example. Another example is in the United States. So they fund through the federal government, through HRSA, the Health Resources and Services Administration, a health workforce technical assistance center, and several centers for health workforce studies that are both regional and thematically focused. They recently released an informative and interactive dashboard to assist in health workforce planning across sectors and states. And this is what's quite interesting and different in the United States. They focus on sectors of importance, rather than just by professions. So long-term care being one of their sectors, mental health or behavioral health being one of their sectors. And they have heat maps to look at the disproportionate supply of health workers across different states. And that helps decision makers figure out where to go with particular sectors. And recently, in October 2021, it released its health workforce strategic plan, including the goal to develop and apply data and evidence to strengthen the health workforce. This is so important. Point of reference, Canada has not had a health workforce strategic plan since 2005. So foundational elements that are required in Canada, and in the policy brief, the discussion is to focus on 3 key elements that will improve data infrastructures, bolster knowledge creation, and inform decision-making. So first, a new data standard and enhanced health workforce data collection. Second, timely, accessible, interactive, and fit for purpose decision support tools, fit for planning purposes. And then building capacity in health workforce data analytics, digital tool design, policy analysis, and management science. So what we said that there are 2 necessary but insufficient steps. So first, the federal government should create 2 data infrastructure and capacity building initiatives. So the first one being an initiative dedicated to enhancing standardized health workforce data, purpose-built for strategic planning and associated decision-making tools for targeted planning by certain sectors, through a specially earmarked contribution agreement with the Canadian Institute of Health Information, or CIHI. Step 2, a special CIHR administered strategic training investment in health workforce research and a complementary signature initiative to fund integrated research projects that cut across existing scientific institutes. I can't have anybody name me one institute for which health workforce is not important. And then we lay out 3 options in this policy paper. And I'm curious about getting people's opinions of these different options. So first, the federal government could create a dedicated health workforce agency of Canada with an explicit mandate to enhance existing health workforce data infrastructure and decision support tools for planning, policy, and management across Canada. And an interesting existing exemplar is the Public Health Agency of Canada, which was created out of our last crisis of SARS. So certainly there should be some legacy for this extended crisis, which has impacted the health workforce so significantly. Other exemplars are all of the international health workforce agencies that exist in pretty much every other country. Option number 2. The federal government could support through a contribution agreement, similar to the other pan-Canadian health organizations, the creation of an arm's length, not-for-profit organization, such as a Canadian Partnership for Health Workforce. And this could be a steward of a renewed health workforce strategy and to provide health labor market information, training, and management of human resources in the health sector, including support for recruitment and retention. And an existing exemplar that we have here in Canada is the Canadian Partnership Against Cancer, one of our pan-Canadian health organizations. The third option is that the federal government could support the creation of a more robust, transparent, and accessible secretariat for a Council on Health Workforce Canada to improve data and decision-making infrastructures, bolster knowledge creation through dedicated funding and policy to inform decision-making, and collaborate on topics of mutual interest. And an existing exemplar is the Council of Ministries of Education of Canada. So none of what we are recommending here hasn't already been done in Canada, and it absolutely needs to be done in this sector. So we really want you to help us to make this a reality. What are some of the things that we need to take into consideration? Who needs to be involved? Because as was mentioned in the call to action, until barriers to effective health workforce planning are addressed through better and more accessible health workforce data, we can expect inadequate planning for population needs now and into the future, inefficient deployment of health workers, exhausting them, burning them out, persistent maldistribution of services, and a perpetuation of current inequities. So please tweet out hashtag #PathForHHR. If you have not yet signed on to our call to action, please do so. We will pop this into the chat so you can have a direct link. And join us in signing an open letter to the expert advisory group of the Pan-Canadian Health Data Strategy to encourage them to make sure that health workforce data is part of the overall Pan-Canadian Health Data Strategy. And with that, I will stop sharing and thank everybody and pass it back to Maggie.
Thank you so much, Ivy. You know, it's interesting when I think about it, we think of the pandemic as being the cause of a lot of the problems we're seeing in the system, but in fact, they have been around for so very long. And hopefully, with this call to action, what we learn from the pandemic can really be used to change how we move forward. So thank you so much for that. I'm going to encourage our panel. I've got specific questions that I'm going to ask throughout the panel, but you know, if you do have anything you want to add, please make sure you do it. I will also ask in the chat, as we go along, please put your comments or your questions there so that we can address them. Linda, I'd like to start with you. You know, so virtually every day, I hear about the enormous strain that nurses have been suffering under during the pandemic. I know that my Twitter feed is full of stories about burnout and the strain that they're feeling. And I'm wondering why it is that a union has been pushing for health workforce planning as a solution to this problem, as opposed to other options that may come to mind more readily, like safe staffing models and collective bargaining, or bonuses, or the promise of permanent positions. So can you help us understand this a little bit more?
Hi, Maggie, and thanks for the question. And at the same time, I hear the question and I wonder, why are they targeting unions on why we're asking for better data? But anyway, today or this year marks the 20th anniversary of the largest report on nursing as a health human resource, the Our Health, Our Future nursing resource. 20 years ago, 54 recommendations were written after the 1990s crisis in nursing, in medicine, and others, because of a report that was written early 1990s and said we had too many doctors, too many nurses. And then it was repeated in 2003, 2007, 2008, 2008. The CFNUs, CNAs, CMAs of the world asked the federal government for $1 billion fund for over 5 years to create an observatory to look at the crisis in health human resource. So we've been around this. And then you see in the 2012, 14, 16, all our reports are talking about we're going to hit a crisis. And that was way before pandemic. So to answer your question more specifically, as a union, we're saying, yes, we need the proper data, the proper planning. So some kind of leadership federally to bring everyone together, all the experts together, to give the data for the province and territories and our healthcare employers to make the right decision. but it goes hand in hand with strategies around permanent jobs, around re-looking at our education system for healthcare professionals. Patient safety means safe staffing models. So all of that has to look. And the new thing that has come up in the last few years, the whole mental health. As you mentioned, Maggie, your Twitter feed is filled with horror stories of what's happening to our healthcare workforce. But let's be honest, we're living these horror stories. Thousands and thousands and thousands of positions are empty. 25 to 40% of our members, which are the working nurses of this country, are telling us, I've had enough, I want to leave. Either go casual, leave healthcare, or pre-retirement. And I see some of the viewers here that were here 20 years ago and said, well, Linda, we talked about early retirement 20 years ago. Nurses were saying they were leaving it. They're saying, well, it's different today because 70% are saying they have severe mental health issues, crisis of burnouts and others. So we need to do something. So we all heard, Ivy, about the 8% of GDP, the 45% of provincial territorial budgets. This is not fluff. We need to address it, and we need federal leadership because it addresses 100% of Canadians' life.
That's great. I mean, again, it just highlights the longevity of this issue and the need for a call to action to really address it now. We've been in a place where this has been an issue for so long and we haven't addressed it. Catherine, I've watched with a lot of interest as the CMA has really intensified their focus on health workforce planning. In fact, the focus is of such importance that the CMA has highlighted the issue as one of the key elements of its strategic plan. And I wonder if you can share with us why this is of such importance to the CMA and to doctors in Canada.
Thank you. And thanks, Ivy, for your presentation and Linda for your comments. And I think there's a lot of what you talked about very much applies in medicine. I think what we're seeing, like all the other health professions, is just a growing crisis in the health workforce and a real lack of understanding across the country really about why and what that means. So, I think the best example in medicine is in primary care. We know there are over 5 million Canadians who do not have access to primary care, whether that's a physician, a nurse practitioner, a healthcare team. The bottom line is they are not accessing longitudinal care. And why is this? What are we doing about it? What is our plan to address this issue? And I think, in medicine specifically, I think this is probably our biggest human health resource crisis is in that area. And I think it's multifactorial. And I think because we haven't been collecting the data, we haven't been understanding why that's an issue, what the numbers are, and even importantly, how people want to work nowadays, which has also changed. We sort of find ourselves, constantly talking about this, but not really advancing any solutions. And at the same time, what do we have? We have Canadians have worse healthcare outcomes because we know primary care is critical to reducing need for the acute care side of our hospital system. And we're seeing, obviously throughout the pandemic, this problem worsening. And then in addition to that, increasing pressures on our hospitals that are creating all sorts of other acute care backlogs. So I think at the CMA, we really feel that this has to be a key priority on many levels. If we don't clearly define or understand the problem we're trying to solve, it's very difficult to then put in place solutions. And I think, we all know human health resources are a problem in a crisis. That's not a debate. And it's not only in medicine or nursing, it's across all health professions. And I think that's really very key. But what we don't really understand is, what is exactly going on there? What, especially, for myself, speaking of medicine, why do we not have people in primary care? What is happening to the people who train in primary care? What are the barriers for people taking on longitudinal family practices? And how are we accounting for that in our training, both who we're attracting into medical schools and then also who's going on to postgraduate training and how we're training them? We're hearing from younger physicians, they want to work in integrated teams, provide team-based care. Well, what are we doing about that? Where's the data on how that training is being provided, and then what the employment opportunities are in those types of spaces? So I think, we not only are lacking in data in terms of what's the right ratio of physicians to the population, where should people be situated in terms of location, but we're also really lacking an understanding of how do physicians work this day and age. How does that compare to the way the system was designed in the 60s? Is it sustainable? Is it drawing the right type of people into medicine? And are we creating an environment that allows those people to thrive? And I think what I'm seeing so much, and I think it very much parallels what we're hearing in nursing, is instead of the system really supporting people and allowing them to thrive and do their best, it's the opposite. The system people are working in is tearing them down. It's contributing to mental health problems, levels of burnout that we've not seen before. So people are finding other things to do. And I think in medicine, what we're really seeing is that shift away from people wanting to do longitudinal primary care, because it is the area that has some of the highest rates of burnout due to the increasing administrative burden that has been exponential as we've integrated things like EMRs and other tools that should be making people's lives better, but actually are creating more work. So I think we really feel that, human health resources are at the heart of healthcare. We know that we need to be doing team-based care. We know that we need people to have access to medical homes. And we really feel without the data and a way to monitor that. And again, data has to be more than just numbers. It has to be understanding, how do people work? How do we leverage different styles of practice? How do our models of care, models of payment work or not work to incentivize the type of care that we want? So until we're really understanding that, how do we actually move forward with any solutions? And I think what we've seen is, in the last 20 years, we've gotten nowhere. We're no better in terms of serving the needs of Canadians, especially in the area of primary healthcare. Even though more dollars are being spent on healthcare, we're not necessarily seeing better outcomes. So I think we really feel that, absolutely more investments needed. But if we don't really know what we're trying to do with that investment, are we just going to get more of the same? And I think what we want to see is value for that investment. We want to see a healthcare system that's meeting the needs of Canadians through that whole journey, from in the community through to the acute care setting and back into the community. But to be able to do that, we need the data to understand what we need at each of those places. We need to understand how people want to work and are able to work. And we need to make sure that we're creating workplaces that allow people to thrive. And that's key for patient safety, quality of care, and retention over the long term. So right now, without that data, without this integrated lens on planning, I think what we get is a lot more resources being poured into the bucket with the empty bottom, and it's not really achieving the change that we want to see in the system.
Catherine, it's so interesting, when you talk about the fact that the system doesn't meet the needs of healthcare providers currently. I often think about the fact that the system was developed so many years ago to meet a different demographic, the needs of a different demographic and different needs. And we don't always consider that it also doesn't meet the needs of those providing care. So it's a really important insight. Thank you. I'd like to switch gears a little bit, Eric. And I'd like to talk a little bit about your work leading the Pan-Canadian Health Data Strategy. The strategy does not explicitly mention health workforce data, which to me was a little bit of a surprise. So it'd be helpful if you could help us to understand why this is.
Sure, very, very happy to talk a bit about that, and thrilled to be here today. The short answer is that it's not that the Pan-Canadian Health Data Strategy work specifically excluded health workforce. It's more that its focuses are on the fundamental foundations of data that underpin all of our systems, inclusive of health workforce and other areas. But let me dig in a little bit too, because for many of you on the call, and you may never have heard of this thing. I have had the honor of really coordinating the work of a group of experts, our expert advisory group, that has been in place since December 2020, that emerged out of the work of the response to COVID-19 to say, how do we ensure that we are better using our data in order to make sure that we don't get that we're able to effectively have the data we need in the cases of future public health events, but also that we are using our data better to improve the health outcomes of Canadians writ large. Sadly, to Ivy's earlier point, referring back to papers in 2010 and 15, I've been reviewing papers for 60 years, notably ones in 1992, as well as papers in the 2010s that have universally called for we must use our data better to improve health outcomes for Canadians, and yet we have not made the leaps that we need to. And so in the expert group, and there are 2 reports that they've published. In the first one, they really reflected on the barriers of why are we not using the data that we have, or effectively using the data that we need in order to answer the questions that we're so desperate to. Some of the comments I've seen in the chat, that in many cases we have data, but we don't even use the data we have well, let alone the data deserts where we don't even have access to data we require, such as for some of the the private health providers, as again noted. The expert group noted that many of the barriers are people, process, cultural barriers. They refer to the privacy chill that is preventing the sharing of data across organizations, and that privacy chill is hampering our ability to answer the questions that we need, to create the silos that we have that have fragmented our data assets across the country, and then we build scaffolding in order to connect those silos of data together that take time to maintain, take time to build, and may not be fit for purpose for whatever new questions arise as the case may come along. And so the expert group really focuses on we have to strengthen our foundations underpinning all of our data assets. And those foundations are our governance, the data governance writ large, to ensure that we understand and trust the data that we have, and ensure that we have the policies in place that enable the timely sharing of data such that the right data gets to the right people at the right time. We need to have the data standards, the interoperability structures to allow that the data when shared is actually understood and is meaningful and is usable by the people who receive it. And all of that is tied up in, we need to ensure that we are doing this in a way that is trusted by Canadians. Data are ultimately a very personal asset. I think we can all appreciate that, both in the context of individuals who are receiving care and as individuals who are delivering care. And in that context, how do we ensure that we are sharing data in a way that is respectful to those individuals in the first place? And what are their expectations, and how do we foster trust in the sharing of information between partners? Oftentimes the privacy chill, again, the expert group noting that the privacy chill has tended to incentivize don't share data because you may cause a breach or may cause an issue, without having a countervalence of if you don't share data, it can actually lead to worse harms in the long term. And certainly Health Workforce is one of those fantastic examples, because data are not shared and are not coordinated in a way wherein we can answer important questions like simply, do we have the supply of health workers to meet the anticipated future demand for those health workers? It's a very basic question by which we have no simple answer, nor any mechanisms in order to affect that answer, certainly a Canadian perspective. So in terms of remedies, in the second report, the expert group really reflected on a high level perspective, embracing stewardship as the evolution of custodianship. They reflected that custodianship is rooted in custody, which is to keep things under bars, keep things under lock and key, whereas stewards, and this is some of the words that were used earlier on, they encourage the reuse and the use of information to affect the public good that we want, while also ensuring its protection. And we really need to embrace this culture of stewardship across the country in and of itself. So 2 last points. One is that the health system around us is really evolving from when it was first envisioned 60 years ago. 60 years ago, it was much more about episodic care where data are captured in analog channels. We care today is much more about chronic care longitudinal care for individuals in a digital way. And in that massive pivot, we need to realize that our health systems need to pivot its approach to the information that it has in order to take advantage of the digital age. One of the poignant points that the expert group noted in its second report is that there is no governance around our fastest growing asset in Canada, being the health data that we have. So we have to have some governance and coordination, and that's where a lot of the things that Ivy and this paper we're talking about really expose some of the opportunities in that space under the slice of data for HHR. The last thing I'll call out is really reflecting on the vision for health data that the expert group posited in its first report, further positing that we don't have a vision for our health data in the country, and as a result, we have many people in a boat rowing madly and getting nowhere because we're all rowing in different directions. And so a coherent direction can be to empower Canadians with their health data envisioned in the context of a learning health system, wherein the experiences of care reflect the quality and safety that we expect. It is through that quality and safety that we expect that absolutely the HHR lens needs to come through loud and clear. And so I'm really looking forward to, as we're working on our third report of this expert strategy, to reflect on many of the highlights that came out through the recent HHR paper, to make sure that we are thinking about data writ large to improve outcomes for Canadians and strengthening our health human workforces as we need to.
That's great. Thank you so much, Eric. So much in there to think about, and so many really great insights. Deborah, it's been quite some time since I worked at CIHI, and I've watched with a lot of interest as the work has expanded and has provided such a wealth of information to the Canadian healthcare landscape. Can you tell us some of the developments at CIHI that might enable what could be considered a really big leap forward in health workforce data quality and accessibility?
Sure, Maggie, thank you very much. Thanks for the chance to be on the panel. I think it goes without saying that COVID has really exposed the limitations of our data foundation in this country. And that goes for many, many aspects of our health care system, HHR among them. Probably it's also safe to say that HHR hasn't seen significant data infrastructure investments in about 15 or 20 years. And, it's one of the reasons that we're starting to come into crisis and not have effective planning and management solutions in this time. We think about the information needs, which are just so vast in health workforce. We need to have understanding of vacancy rates and sick time. We need understandings of models of care and who can do what in interdisciplinary teams. We need information about, who provides care in which organizations, so we can watch whether certain groups are becoming vectors of transmission. We need to have a sense for, will we have enough in the future? And we need to know if our health workforce is doing okay. Do we have adequate health and mental health in our people? One of the things that CIHI has done in the last 18 months is to start to think about what would be a data roadmap or a data and information roadmap for HHR in this country to help address some of the issues that I just talked about and many, many others. And what we've started to articulate was the recognition that there are stranded data assets out there in the country. They just haven't been brought together, standardized, and centralized in an effective way. And there are about 6 areas of data that really, if we could pull those things together, would form a much stronger foundation for HHR in the country. The first of which is expansion of our regulatory data, right? These are data that are collected about regulated professions at a one-time-a-year licensing type of collection schedule. That would be a foundation, but you have to remember that not every health profession that's critical in our crisis, thinking about PSWs is a good example, is a regulated profession. So what do? Well, we need to think creatively about where do those data reside. The data reside in payroll systems across the country, because even if you're not regulated, you are paid. And so if we could get access to the payroll systems across the country and combine those things with the regulated professions, you start to have a much stronger foundation of who in totality is working in the system. And you have a much more effective, timely system because people get paid on a much more regular basis than once a year. But beyond that data foundation around supply, we also need information about service utilization, who's doing what and who is receiving what care. These are critical issues to understanding what providers are providing what services in order to track towards patient outcomes. The fourth thing we need to think about is the scopes of practice, right? So as we've seen COVID change, we've seen scopes of practice be modified. And if you're going to understand new evolving models of care, you have to understand who's allowed and legislated to do what. Fifth, we need education data in a centralized way so that we can understand who's coming up through the system in order for us to forecast for the future. And last but not least, we are articulating that we need much better information and consistent collection of information about the health and mental health of our workforce. The last comment I'll make in this space is that I think Adrian McKenzie makes a really interesting point in the chat, which is the data foundation is important and we need to make investments there, there is no doubt. But we need to lay some things on top of that in order to optimize the power of that data. The data will not come in clean and perfect and centralized and use fit for purpose. We need methods and tools that lie on top of that data. Think about things like the National Unique Identifier we've been working towards for 20 years. Think about things like FTE methodologies so we can effectively count people and what time they're putting into their professions. Those are the building blocks that get us to forecasting models that allow us the much more timely information that we need. It's not enough to have information that's 2 years old. It's not even enough to know what we have 2 weeks ago. We need to know what we're going to have 2 weeks from now and 2 years from now. So there's this whole continuum. CIHI is in the process of articulating that strategy in the form of a 5-year roadmap. And we're working with different partners to talk about that, share that around, and look at opportunities for investment so that we can start to drive towards some of those data foundation pieces upon which we can build for the future.
That's great. Thank you so much, Deborah. I will just remind people, if you do have questions, please put them in the chat. I do want to start with a bit of a double question, I'll call it. So I want to start with Ivy, but then I would be interested in what each of you say. So one of the participants made the comment that any one of the 3 options that were presented, Ivy, means more of a leadership role than a coordinating role for the federal government. So a comment on that. And then also I would like each of our panel members, if you can think about it, is, you know, when we think about what's needed, one of the things that's needed is a clear mandate for planning, and that's currently missing. So who should be accountable for health workforce planning in Canada, and who could or should take the lead? I'm going to start with you, Ivy, and then if I could get each of you to think about that and add your thoughts, it would be helpful.
That's great. Thank you so much. And I really do think that, yes, it is a leadership role, to be sure. I think that there's always this delicate dance between the federal government and the provinces in the jurisdiction of healthcare. But I think that there is a clear need for leadership coordination, whatever you want to call it, but there needs to be people at the table, and to create a table for people to have this discussion in terms of moving forward, recognizing there are multiple layers of complexity here, absolutely. But I think we need to absolutely involve the provinces and territories, to be sure. But I think that there's an importance of coordinating everybody together. And I'm really curious about hearing the other panelists' views on that. Thank you, Maggie.
Maybe I can just go to you, Catherine. We'll start with you if you don't mind.
Sure, thank you. I think this is, you know, as we all are aware, one of the biggest challenges with healthcare in this country is our federated model, where healthcare delivery, of course, happens at that provincial and territorial level, yet the federal government does play a large role as one of the major funders of healthcare. And then, of course, is really the only group in the position to take that pan-Canadian lens to any particular problem with the health workforce or the healthcare system. I think what's challenging also sometimes is, the provincial governments want a lot of autonomy over the way they deliver healthcare, but they want the federal government to fund. The federal government, of course, wants to see value for its investment. And I think that's why we're starting to see more targeted funding and expectations from the federal government that the investments they're making are tied to certain outcomes or certain types of investment. And I think that same challenge permeates in this space of the health workforce. But what I'm hopeful of, and maybe this is overly optimistic, but I think just with the pandemic and how clear we are now in this really extreme crisis, like as everyone said, this is not a new problem, but it's reached a new level, that I'm hopeful that the provinces and territories will start to realize that the status quo is really not working and there needs to be more cooperation to solve this. And especially when it comes to the human health workforce that can, of course, move across the country, if we do not have any pan-Canadian lens on what's going on, it's also not really servicing the provinces and the territories either, right? If they're losing health workers, they may not really know to where or to why. If they're not looking at how what they're offering their human health workforce compares to other locations, it may be hard to understand, how do you attract people into your location? So I do think that there needs to be a role for the federal government in terms of providing leadership and coordination. I think their challenge is really the willingness of the provinces and territories to participate in that process and them seeing, I guess that this is a valid role for the federal government and wanting to partake in it. I'm hopeful that we could all agree that our health system really is at a level of crisis that it's not been before, and we're not going to solve this by staying in our silos, and that may motivate the provinces and the territories to come to the table in good faith and recognize it's actually in all of our interests to work together, especially around the issue of data that really does need to be pan-Canadian. But of course, that it's a lot of distinct interest groups to try to bring together, and whether that happens, it's challenging. And then, of course, we have the different election timelines, the different politics behind decision-making. So there's, I think, a lot to coordinate. But I think once that structure is there, and if we can get the impetus to do that, then I think it'll be harder for provinces and territories to make a case in terms of why they wouldn't participate.
Great, thank you. Linda, I'm wondering if you have any thoughts on that. I'm sure you do, as representing the nursing profession.
Catherine is right. There's always that federal, provincial, territorial ball tossing. But I've worked with province and territories for 1,000 years. And if you show them concrete proof, concrete plan, and money attached to it, they join into the big picture. From anything, we can look at the changes they did on CPP. You can look at the changes we've done on healthcare in general. 20 years ago, we weren't talking mental health. We were hardly talking long-term care, or never mind home care. Primary care, people couldn't even spell it. So now we are talking about same language. I think about all the wordsmithing. Is it a coordinating or a leadership role the federal government should do? Like, really, you heard Ivy's 8% of our GDP. It covers 100% of people living in Canada. Yes, it's a federal role that we call it what we want. And Deborah and Eric so eloquently talk about data smithing. We cannot make the right decisions if we don't have the proper data and the proper strategies attached to that data. And the proof is in the pudding, my friends. The province and territories and healthcare employers have failed royally. Look at the mess we are with this healthcare workforce. We need to look at the lifespan of our workers. You've all talked about that. And we need to look at the evidence that guaranteed or at least aimed at patient safety. And then ask ourselves, there's 104 people on this call, ask ourselves, why are we still asking for health workforce to be a priority for all governments? Why are we still asking that question? The federal government and politicians in general are playing the chicken game. They listen to a policy shop instead of listening to the healthcare professional, the healthcare workers, and those who devote their lives in strategies, in better planning and better delivery of healthcare services. Yes, I'm a bit frustrated because it's been over and over and over. For Ivy working at the end of her desk in June to get 60 organizations to sign on to this call to action within 2 weeks was phenomenal. It's because we all realize we need central leadership on this.
I think, Linda, that leads me sort of to that other part of the question, which is who should be accountable for health workforce planning in Canada and who could take the lead?
It has to be the federal government. We're way too of a small country. I always use the example of California. We have about the same population as California, and we have 13 different systems, 13 different gods of healthcare, and they all, oh, let me do my own thing. Sorry, like look at Premier Legault. Gave bonuses and bonuses outside the collective bargaining process, and it failed royally. It, had to get back and send nurses memos. Oh, sorry, can you give me back the money? Yeah, right. We have to have one strategy and one leadership, but also going to Deborah and Eric's comments, we need accountability. We need good governance, and we don't have it. Look at our long-term care fiasco. It's embarrassing that we're one of the countries with the highest level of seniors debt in this pandemic, when we have one of the most beautiful healthcare delivery system. We're just managing it very poorly.
Yeah. Deborah and Eric, Linda has mentioned the importance of the comments you made around the data. If we had a significant investment and could launch a comprehensive data infrastructure, how would you each envision optimal collaboration and coordination among all the multiple stakeholders that we've been talking about to not only collect the data, but to produce and disseminate evidence? I guess what I'm asking, in other words, is what's really needed to foster the interaction among all the professions involved so that we can put this siloed approach that Linda speaks about so passionately behind us once and for all?
So I will take a crack at it first and give Deb time to collect her thoughts so she can give the smarter response in the back end. She and I have done this but dog and pony thing a lot. I think we've heard so much of the need for collaboration. The terms that I've heard used are, we need to be moving from conscious or unconscious competition to conscious collaboration. We need to be thinking about what are the ways where we can partner, reuse, do things in a way that will actually answer questions tomorrow that we know we're going to have, but we don't know what those questions are. And so how do we actually make it easy for us to create the environment for us to be able to answer those questions tomorrow? And how do we incent people to participate in those systems? Those are the types of things we need, but really it has to be a partnership of equal partners. And the last thing that I'll say is, I think there is a great opportunity here to activate the public, which one of the things that we had done is done a few discussions with groups, including doctors and nurses and several other parts of the health workforces across the country. But my favorite comment that I received out of any of the sessions was one we have with patients, which was simply, if you do not trust me with my data, why should I trust you with my data? And I thought that really hit things home, but it equally applies from a health workforce perspective. If you're not going to trust me with the data that I have in order to deliver the best outcomes for the patients that I'm seeing, how do we actually create that environment? If the public understood the challenges that we have, and I think I saw in the chat the reference to the safety that the lack of sharing actually can reasonably create, I think they may actually get much more on board and behind us to actually create the action that we need. Deb.
That's great. Thank you, Deborah. Over to you quickly, and then we'll move to our last question.
Sure, thanks. I think there's a few models that we could think about with respect to leadership, and Ivy's work has really outlined 3 viable options. So I won't comment on who should lead. I think my final comments will be around what does that mean? And I think the most important decision we need to make around leadership or recommendation principle is that leadership, whoever is going to lead, cannot do it alone, right? There are multiple actors in this space. They all have a role to play. They all have a mandate and something to contribute. And so a leader must, whoever that group is, must take on a neutral convening role in order to acknowledge the multiple actors in this sector and the value in things that they contribute. The partnerships that collaboration will establish, I think, need to be mutually beneficial. So not just one of our players benefits, but all of the actors benefit from the direction forward. And I would just, as the data nerd, I just pose one last thing. The data is really fundamental, but it's the access to that data in an equitable, useful way across those multiple system actors in a neutral space really will allow us to facilitate that collaboration, so that we're all getting what we need and all deriving the value from the partnerships that we're participating in.
Great. We have one last question that we may not get fully answered, but that I will leave you with to think on as well. Margaret asked a question, recognizing that Canada is part of a global community and should get its house in order before recruiting internationally. So I would like to throw that to the panel for a quick comment before we wrap up. Linda, can we perhaps start with you on that one?
You know, it's a lot of repeat. We know there are best practices out there. We know they exist. We just have to do it. You know, I was putting in the chat Deborah's line. I think it's the best line today. Whoever is going to lead can't do it alone. And we have to learn from others. And no, there's not one perfect system, either domestically or internationally, but we have to learn from others and we have to implement those best practices. And
Right.
the research too, it's not all about data. It's all not about even you data nerds. It's about experts analyzing the data and bringing strategies that will concretely work. And that's the evidence. That's putting knowledge to power, and we need to do it.
Great. Listen, thank you so much. I cannot believe this hour has flown by. So much to think about, so many wonderful contributions. Thank you so much to each of the panelists here and to everyone participating for your involvement, your interest, your questions, your comments. And I'm going to, with that, just thank you for being part of today, and I'm going to hand it over to Ivy.
Thank you so much, Maggie, for coming in as our moderator at the last minute. Really, really want to give you a shout out and appreciate that. I really want to thank all of the panelists. This is a complex problem that is reflected in the comments in the chat. Thank you, everybody, for being engaging. And I also just want to close by apologizing to those who registered, and for technical reasons, Zoom didn't increase our capacity. So there were many, many more people who wanted to be in here. We are going to make the recordings available to them right away. And so we'll send that link out to them, but I did want to give that apology at the end. So thanks, everybody. Please continue the conversation. This has to go forward, and please reach out to any of the panelists if you have any additional conversations subsequently. Thanks, everybody. Good afternoon.